everyone. This is Dr. Vidya, one of the mentors of Study MRCOG. Welcome to MRCOG Part 2 RRR YT series, and today's topic is urogynecology. So let's discuss some important points of urogynecology, mainly focusing on topics incontinence, vault prolapse, POPQ, and BPS. Okay, so let's start with a quote always. Time is non-refundable, spend it wisely. So your July exam is nearing, so please spend your time wisely. Now, coming to our topics. So urogynecology is a very simple and straightforward module. So don't miss this module because there are some sequence of steps both in the evaluation and management. And if you know the correct sequence properly, you will get straightforward questions from this module, right? So let's first discuss the topic incontinence. So incontinence, mainly we have two types, stress incontinence and urge incontinence, right? So coming to the important points about evaluation and management. First, look at the investigations or evaluation. So always when a woman comes with lower urinary tract symptoms, the first test to be done is urine dipstick to rule out UTI, right? So this will be the first look for this, whether a urine dipstick is done or not. And so if the woman has symptoms and if the urine test is positive for leukocytes and nitrates, then you have to send urine culture and also prescribe antibiotics while awaiting the results, right? So symptoms plus urine test positive, prescribe antibiotics and send urine culture. If symptoms are present but urine test is negative, then you still send a urine culture and you still consider prescribing antibiotics while you await for the results. So remember here, look out the word consider. So in many of the RCOG guidelines, you will have these words offer, consider. This is most important because even in the question, even in the MCQ, you will get the exact words. So if the symptoms present but urine test is negative, consider antibiotics. Okay. Next, the other case scenario is if there are no symptoms but if you have happened to do urine test and if the urine test has come positive for leukocytes and nitrites, then you send urine culture and do not offer antibiotics without the results of the culture. You have to wait for the urine culture report, right? So this was our first investigation, that is urine dipstick, right? Next, coming to the second investigation, that is post-voidal residual volume. You do it either by catheterization or bladder scan, preferably bladder scan because it is comfortable to the patient. So the scenarios where you need to do is PVR is whenever, if the woman has voiding dysfunction, like, slow stream, intermittent stream, so voiding dysfunction, or if the question says if she's suffering from recurrent UTIs, right? So these two are the scenarios where you need to assess post-voidal residual volume. So this is not done routinely. So please look out for these symptoms. Okay, so if there are these symptoms, next test will be PVR. Next is the most important test, that is bladder diary, right? So this is used in urge incontinence. So whenever a woman has urine urge incontinence or symptoms of OAB, that is frequency, nocturia, urge incontinence, then after urine dipstick, your next line of investigation will be bladder diary, which you will be asking the woman to keep for 3 days, including work days and leisure days. So basically, she will record input, output, and the leakage episode so that you can identify the trigger and address it. Okay, so this is bladder diary. Next investigation is urodynamic study. So this is one of the most important investigation, and please remember, this is not done routinely. You have some specific indications mentioned in the guideline for which only you will advise UDS, right? So what are those indications? So one is urge predominant mixed incontinence, right? If there is mixed incontinence but urge predominance, or if the type of incontinence is not clear, or symptoms of voiding dysfunction, or if there is anterior or apical prolapse accompanied with this symptoms, or history of previous surgery for SUI. So these are some specific indications for whom you will suggest UDS. So if there is a clear-cut case of stress urinary incontinence, like if the woman has come with leakage episodes with stress or exertion, like with cough, and on examination also, if you find clear-cut SUI, then you need not do urodynamic study to confirm it. You can directly offer her the management option, including surgery. Okay, so this is one of the most important thing. So let's see one question. So a 60-year-old woman presents to gynecology clinic with a 6 months history of urgency, daytime frequency every hour, nighttime frequency of 3 to 4 times. There is no urge or stress incontinence. She had 3 proven urinary tract infection over the past 6 months. She's postmenopausal, not on HRT. Vaginal examination is atrophic external genitalia with grade 1 cystocele and rectocele. Urine analysis showed positive RBCs and positive leukocytes. What is the most appropriate next management step? So here you have got bladder training, urodynamic study, urine microbiology, and cystoscopy. So here the most important keywords are 60 years. So older woman with OAB symptoms, urgency, frequency, nocturia, with history of recurrent UTI, and urine analysis is showing hematuria, right? So urine analysis showing hematuria in an older woman, always rule out calculi or malignancy. So, okay, so then here your answer will be cystoscopy. Okay, so this is the role of cystoscopy in the OAB symptoms or lower urinary tract symptoms, right? So, right. Now, let's see the next question. A 50 years old woman with 2 previous vaginal delivery has undergone mid-urethral sling procedure for SUI 10 years back. Again complaining of SUI, but no urgency. She has strong pelvic floor muscles when assessed. What is the most appropriate management option? Okay, so you see, so this is a case of SUI with previous history of surgery done for SUI, right? It's a recurrent SUI. Here, although you see Birch corpus suspension, it is the line of management, duloxetine, intraurethral bulking agent, all these are management for SUI. But because it's a case of SUI with the previous history of surgery, always first do urodynamic study. So here the answer will be urodynamic study, right? So I hope this is clear. Now, so these were about the investigations. Let's deep dive a little more. Let's see a little more about urodynamic study, right? So see, frequency, urgency, nocturia, all these are symptoms, right? So this symptomatic term is called overactive bladder. Overactive bladder is a symptomatic term. If it is proven on urodynamic study, then you call it as detrusor overactivity. And this detrusor overactivity can be with or without incontinence. Remember this, right? So if in urodynamic study, so let's see, suppose if you have got a graph of urodynamic study. So always first look at P detrusor graph. That is a simpler way. So if there is contractions in the P detrusor graph during filling phase, then it is most likely detrusor overactivity. Okay, because during filling phase, you shouldn't be getting detrusor activity, right? During voiding phase, there should be detrusor contractions, increase in vesical pressure that helps in voiding. But in filling phase, you shouldn't be getting detrusor contractions. So in filling phase, if there is detrusor contractions, then it is most likely detrusor overactivity. And if it is associated with leak, then it is detrusor overactivity with incontinence, or if there is no leak, then it is without incontinence, right? So this was about OAB and detrusor overactivity. Coming to stress urinary incontinence, you know that it is leak on cough or increased abdominal pressure. If that is proven on urodynamic study, then it is, the term is called urodynamic stress incontinence, right? So what you will see in the graph. So first always look at P detrusor. So there should be no contractions in P detrusor. Okay. Then you see P abdomen and P vesicle. So if there is rise in P abdomen along with rise in P vesicle with leak, then it is stress urinary incontinence. Okay. So usually also in any woman, when there is rise in pressure in abdomen, it is obviously transmitted to the bladder and there will be increase in P vesicle, but it will not be associated with leak in a continent woman. But if the increase in P abdomen is associated with P vesicle with leak, then that is stress urinary incontinence. Let us see this example. See, you can see this graph. So first look at P detrusor. P detrusor, no contraction. P abdomen, there is rise in pressures with rise in pressures in P vesicle, and you can see there is leakage. So this is a urodynamic stress incontinence, right? So next, you see this graph. So you see the first part, there is written CG, that is cough. So with cough, you can see that the blue line, that is P vesicle, is increasing with P abdomen, right? The red line, but there is no leak, right? So this is not SUI. And the next part you see. So during filling phase, there is contractions seen in the P detrusor. So this should be more likely detrusor overactivity, right? So see, there is contractions in the green line along with increase in P vesicle pressure, that is blue line. And on top of it, you can see FD and SD, that is first desire and strong desire. So there is symptoms of urgency also. So this is a graph of detrusor overactivity without leak, but there is no leak mentioned, right? So this is a detrusor overactivity without leak. Okay, so these are some graphs. So again, you can see this. So here there is first always see P detrusor. There is no contractions in the P detrusor, so it is unlikely detrusor overactivity. Next, you see P abdomen, P vesicle, and check whether there is leak or not. So there is increase in P abdomen and there is increase in P vesicle, and you can see up at the B part, there is flow positive leak. Okay, so this is a case of SUI, P abdomen plus P vesicle rise plus leak with absence of increase in contractions in P detrusor, right? I hope this is clear. So this was all about investigations of incontinence. Coming to the management, so there is again, even in the management, there are specific sequence of steps which you need to remember exactly, right? So first, look at stress urinary incontinence. First is always lifestyle interventions. So look at the question. If it is mentioning BMI more than 30 or any increased fluid intake, all this. So first, address those. So first answer will be lifestyle intervention. If that fails, the second line, the next option, that is next option in the first line will be pelvic floor muscle therapy, because SUI is a more of anatomical problem where there is problem in the urethral sphincter, intrinsic urethral sphincter, or urethral hypermobility. So pelvic floor muscle therapy, which is to be done for 3 months, that is 8 contractions 3 times a day for 3 months, right? So this is the first line, lifestyle, and then PFMT. If PFMT fails, the second line will be surgeries. So what are the surgeries? So surgeries are Birch colpo suspension, which can be done both laparoscopic and open. And next is autologous rectal facial sling. Okay, so these two are the recommended ones in the guidelines. You can consider retropubic midurethral sling also, but you have to counsel the woman because it is a, it involves mesh, so it is permanent. Complete removal may not be possible. Right, after counseling, you can consider retropubic midurethral sling as well. And the type of mesh which is used is type 1 polypropylene macroporous mesh. Okay, so these are the surgeries. Next, what is the role of medical management in SUI? So the only drug approved for SUI is duloxetine. So duloxetine is a selective SNRI, selective serotonin noradrenaline reuptake inhibitor. So this is not routinely offered even as second line. So please remember this. Okay, so the second line will be surgeries, not medical management. You offer duloxetine only in a woman who is, who has tried lifestyle intervention, PFMT failed, but she's not willing for the surgery or surgeries are contraindicated. Then that is the case you offer duloxetine because it has got a lot of adverse and side effects. Okay, right. Next, what is the role of intramural bulking agent? So this is offered when the surgical procedures are not suitable or acceptable to the woman, okay? Because these are permanent injectable materials and which are given into the urethral submucosa, which increases the coaptation of the urethral mucosa. So, but what it is a temporary procedure and it requires repeated injections. So if the woman is not ready for invasive surgeries, then you can go for intramural bulking agents. The last resort is artificial sphincter, which is rarely done. Now, let's see this question to understand better. So, a 55-year-old woman presents to urogynecology clinic with recurrent SUI. She underwent a retropubic midurethral sling 5 years ago, but her symptoms have gradually recurred. She has completed supervised PFMT, but no benefit. She is highly anxious about further mesh surgery due to recent media coverage, and she seeks a minimally invasive options with quicker recovery. What is the next step in her management? Okay, so let us see the options. You see, option A is midurethral sling surgery, right? So you can do repeat midurethral sling surgery, but it involves mesh, right? And she's anxious about mesh, so you cannot go with this option. Let's keep this B option aside for now. Let's see colpo suspension. Colpo suspension is a very effective method of management, but then she wants a minimally invasive one. So you can't go with this. Option D is artificial urinary sphincter. Again, this is a last resort, rarely done. Next is intradetrusor botulinum injection, which is done for urge incontinence, not SUI. So here the option you can choose is urethral bulking injection. Okay, so in a woman who is unwilling for further mesh surgeries, so this you can choose, right? So I hope this is clear. Now, this was about the management steps of stress urinary incontinence. You have to remember the exact sequence. Okay. Next is urge incontinence. Okay. So the first line of management in urge incontinence again will be lifestyle modification. So first look out in the question about high BMI or caffeine, fluid intake. So your answer will be first the lifestyle modification. Next, if that is already done, but still she has got the symptoms of urge incontinence, then the next step of management will be bladder training, which is to be done for 6 weeks. Basically, here what you will do, you will ask her to control her urine for regular intervals, increasing the intervals gradually. Okay. So this is bladder training, which is to be done for 6 weeks. Next line will be anticholinergics or mirabegron. Okay, so remember, urge incontinence, first line after lifestyle and bladder training is medical management, unlike in SUI where you went for surgeries. Okay, here it is medical management and the drugs used are anticholinergics and mirabegron. Okay, let's see some important points regarding them. So anticholinergics, the first drugs are oxybutynin, tolterodine, and darifenacin. Any of them you can give as a first one, and then you have to review the woman after 4 weeks. Okay, so these are immediate preparations of oxybutynin, tolterodine, and darifenacin. Okay, and you will get these questions like if she has been started on one of the drugs and you have reviewed her after 4 weeks and there is no improvement or suboptimal improvement, or if she has got side effects, what will be your next step? What will be a next step? First, always try to change the dose or try alternate medicine. Okay, like if you have given her oxybutynin, then try tolterodine or darifenacin. That should be your answer. Okay, and if she's still got the side effects and if she's unable to tolerate oral medicines, then then the next option will be transdermal route. Okay, this transdermal route has got lesser side effects, so that will be a second option. Next, if the question mentions that she has used all the anticholinergics, both oral, transdermal, but it is not effective, or if she has got contraindications for anticholinergics. So I have mentioned some contraindications for anticholinergics also, which you can go through and look out for these contraindications in the question as well. So if there are any of these contraindication, then that is where you have to offer her mirabegron, right? Mirabegron is a beta 2 selective beta 2 agonist which acts on bladder muscle and relaxes it, right? So this is where you have to give mirabegron. And again, remember the contraindications for mirabegron, which is an uncontrolled hypertension wherein you cannot give mirabegron, right? Next, you might get this question also, like if the woman is old, if like probably 80 years and she's friable, like she's got a lot of morbidities, then that is the case you should not give oxybutynin. Okay, older and friable women, do not choose the answer oxybutynin, because oxybutynin is lipid soluble, it passes blood brain barrier and affects cognition, right? So these are some important questions which you can get from medical management, right? So this was about the first line. Now, what is the second line management option for urge incontinence? So second line options are botulinum toxin A and percutaneous sacral nerve stimulation. But please remember, before you offer second line options, if already first line options are done, then your next step in management will be doing a urodynamic study before you offer her second line management. Okay, always do a urodynamic study and confirm whether detrusor overactivity is causing these OAB symptoms or not. If not, then you have to discuss the case in a multi-MDT meet. Okay, so before you offer botulinum or percutaneous sacral nerve stimulation, please look out in the option whether UDS or MDT is given, then you have to choose that. Okay, so once you do that, then you can offer second line management, that is intravesical botulinum toxin A. Okay, but you again have to see if the woman is acceptable of these because it needs intermittent self-catheterization. So she should be willing to do intermittent self-catheterization. She should understand the risk of recurrent risk of UTI. So if she's willing for that, then you can offer botulinum toxin A, which is given as 100 units over 20 sites in the bladder, 10 units per site. And again, you will review the woman after 12 weeks. If required, if there is suboptimal response, then you will increase the dose to 200 units. Okay, so this was about botulinum toxin A. Next, when will you offer percutaneous sacral nerve stimulation? If she is not accepting, if she's not willing for intermittent self-catheterization, then that is the case. You will go with this percutaneous sacral nerve stimulation, right? Next, coming to the third line. Third line are surgeries, augmentation, cystoplasty, and urinary diversions. They have got a lot of side effects. So this is rarely used. Okay. Let's see this question to understand better. So Mrs. Margaret, 59 years old, multiparous, post-menopausal woman, presented with urgency and frequency. She was on bladder training and medications, which was of no benefit. Urodynamic diagnosis is detrosar overactivity. She is not willing to accept the risks of needing to self-catheterize. The further option that should be offered is, so as I was telling, so see, in this question, you can also understand the sequence of management, right? So first, she was given bladder training. Next, medications. So these were the first line, which was of no benefit. Then urodynamic study was done. So which confirmed detrosar overactivity. Now she is left with two options in the second line, botulinum toxin A and percutaneous sacral nerve stimulation. But she is not willing to accept the risk of self-catheterization, right? So that's where you go with percutaneous sacral nerve stimulation, right? I hope this is clear. So this was about the management of urge incontinence. So this was all about some important points in incontinence topic. You just have to remember mainly the sequence of steps in the investigations and management, right? Next, coming to the next topic, vaginal vault prolapse. So this is post-hysterectomy vault prolapse. This is when the vault or the cuff scar descends less than TVL minus 2. Okay, descends below TVL minus 2. That is where you call it as vault prolapse. Let's discuss some important points. So first is prevention. How do you prevent vault prolapse? So during hysterectomy, the first one recommended is McCall-Culdiplasty at the time of vaginal hysterectomy. And this is the most effective one with a success rate of 98.3%. Okay, so your first option will be always McCall-Culdiplasty. Next one recommended is suturing the cardinal and uterosacral ligaments to the vaginal cuff, which can be done both abdominal and during abdominal and vaginal hysterectomy, right? The next option will be sacrospinous ligament fixation, which is again a vaginal procedure done at the time of vaginal hysterectomy. But again, you have to look out for these words. So these are the words which are of importance because your MCQs are framed like that. Okay. So if the vault descends to the introitus during the closure, then your option, prevention option will be SSL, not McCall-Culdiplasty. Okay. So look out for this word. So these are the prevention steps. Now coming to the management of vault prolapse. As usual, always go with conservative first, then surgery. So conservative, even in the vault prolapse, you can offer pelvic floor muscle therapy for stage 1 and stage 2. Next, you can also go with the vaginal pessaries for stage 2 and 2 to 4. Okay. So this was about conservative management. Next, coming to the surgical management. So surgical management, you have two important surgeries and many of the questions are framed around this surgeries. Let's understand this. So first one is abdominal sacrocolpopexy. So what is it? As the name suggests, it is done abdominally. Sacrocolpopexy. Sacro is sacrum, colpo is vaginal vault. So basically what you are doing, you're suspending the vaginal vault to the anterior ligament of the sacrum via a Y-shaped mesh. Okay, so this is the procedure. Now, this has got a very good success rate of 78 to 100%. So always choose this, okay, mostly. But it has got side effects relating to the mesh, especially mesh erosion, which is seen in 2 to 11% of the cases. The major advantages of this procedure is it is very effective. Therefore, lower rate of recurrence, lower rates of dyspareunia, lower rates of post-operative stress urinary incontinence. You can remember by the word RDS, recurrence, dyspareunia, SUI, right? So if the question mentions she is sexually active and she has already got a history of dyspareunia or shorter vaginal length, then you will go with this procedure because it has lower rates of dyspareunia. Okay. Next, the next procedure is sacrospinous ligament fixation. So this is done via vaginal route, wherein this is usually done unilaterally, mostly on the right side. As the name suggests, sacrospinous ligament fixation. Basically, you are anchoring the vaginal vault to the sacrospinous ligament through sutures. Okay, so the advantages of this procedure is early recovery. Okay, because it's a vaginal procedure, it is obviously less expensive, less operative time, early recovery. So it's basically a simpler procedure as compared to abdominal sacrocolpopexy. But then recurrence is less with the abdominal sacrocolpopexy, and also high incidence of post-operative anterior compartment prolapse and SUI, because with this procedure the vaginal apex will be directed posteriorly after this procedure. So all the abdominal pressure will fall over the anterior aspect, leading to anterior prolapse and SUI. Okay, and also because pudendal nerve may be involved during the sacrospinous ligament fixation, there will be post-operative buttock pain in 18% of the cases. Okay, so this thought, when will you choose this option is when, suppose if the woman has got history of multiple open abdominal surgeries previously, where you cannot go with this major procedure like abdominal sacrocolpopexy, and if she's not sexually active, then you can go with sacrospinous ligament fixation. Okay, so this was about the management options for vault prolapse. There are some other management options mentioned as well, which is not so important. That is high uterosacral ligament suspension. This is not routinely offered because of ureter injuries, and transvaginal mesh kits. This is also not first line because mesh, due to the lot of mesh complication. Next one is colpoclesis. So colpoclesis can be an again very important option. So if the question is mentioning woman is old, frail woman who do not wish to retain her sexual functions, like suppose if like 60 to 80 years woman with a lot of medical comorbidities like cardiac risk, lung risk, and she's not been sexually active and she has got vault prolapse. So that is the case where you will go with the option of colpoclesis. Okay, because it is less invasive compared to the other options, and it is effective as well. But then because you just close off the vagina, you cannot retain her sexual function. So this is the case where you will go with the option of colpoclesis. I hope this is clear, right? You have got three options: abdominal colpoplexy, sacrospinous ligament fixation, and colpoclesis. Next, let us see this question. A 60-year-old woman with severe vaginal vault prolapse is planned for sacrocolpopexy. She reports no SUI, but on prolapse reduction, she leaks during cough. What is the best intraoperative strategy? So this is a woman with vault prolapse who is planned for sacrocolpopexy, but when you reduce the prolapse, there is leak. So what is this? This is an occult SUI. Okay, so because of the prolapse, the SUI was masked, but when you reduce it, you can see the leak. So for occult SUI, what you can do along with sacrocolpopexy is, let's see this slide, right? So you see, what are the concomitant surgeries for SUI? So if the woman was previously continent, or if she has occult SUI, then colposuspension is the recommended one. Birch colposuspension at the time of sacrocolpopexy. So this will be your answer. Birch colposuspension at the time of sacrocolpopexy will be an effective way to reduce post-operative symptomatic SUI. Okay. The other scenario is if she has got overt SUI, means there is proper leak without even reduction, then colposuspension will not be effective. Then you have to go with concomitant mid-urethral sling procedure along with vaginal approaches like sacrospinous ligament fixation, right? Mid-urethral sling procedure along with SSL. That's where you can do this. Okay, so this also can be an important MCQ and it can be confusing. So please understand this slide clearly. Okay, I hope this was clear. Let's see some questions about POPQ. Okay, so so POPQ, all please read that POPQ staging till stage 4. You need to know that in and out. And also you need to know this this POPQ grid. You need to know all these points, what are all A, B, A, C, everything. Okay, so now let's see this example. So you can see here, anterior compartment points are A, B, A. So this is -3, -3. That means anterior compartment is normal. You can also see there is no D point. That is, this is a post-hysterectomy case. Okay, and C is at -6, which is also normal. Next, coming to the posterior compartment points, that is AP and BP, which are at +2, +5. So there is posterior wall prolapse. And so first thing, posterior wall prolapse. Now, what is the leading most point is BP, right? BP is at +5. So this is the most leading point. Now, based on the most leading point, you have to decide what stage it is, right? So that is +5. So it is not stage 2, because stage 2 is -1 to +1. So it is whether to how to decide whether it is stage 3 or stage 4. So this is, let's see, let's do TVL -2. 8 minus 2 is 6. It is lesser than 6, right? +5 is less than 6. So this is stage 3. Okay, if it is more than TVL -2, if it is TVL -2 or more than it, then it is stage 4, right? So this is stage 3, posterior wall prolapse. I hope this is clear. Right. Now coming to the, let's see the next grid. Okay. So the anterior wall points are +3, +5, +8, right? So there is an anterior vaginal wall descent. C is also at +8, right? Next, look at the posterior wall points. Okay, there again it is +3, +5. So there is posterior vaginal wall descent as well. Okay, so all the points have come down. So now what is the leading point of in this? +8, right? +8 is the maximum point, that is cervix, right? So this will be apical or central prolapse, because see, D point is also there. Therefore, it is not post-hysterectomized. Uterus is there, but the leading point is the cervix. So there is descent of uterus along with the cervix, along with the anterior vaginal wall and posterior vaginal wall. This is called as apical or central prolapse, where the uterus along with the cervix has come down, right? And the stage is, how do you give the stage? Based on the most leading point. Leading point is +8, and it is TVL -2. 10 minus 2 is 8, right? So this is at 8. So this is stage 4. So this is stage 4 apical prolapse. So based on this example, I think it will be clear how to stage and how to read a POPQ grid. So you can directly get a POPQ grid asking for the stages and type of the prolapse, or you can get management options as well. Okay, right. Now this was about the walled prolapse and basics of POPQ. Next, our next topic is bladder pain syndrome. It is a very small topic, and even if you have got no time, just go through the definition of bladder pain syndrome and a flowchart, management flowchart, which is mentioned in the end of the guideline. If you just go through it in and out, then that will be sufficient for your MCQs. Okay, so what is the definition? So if the question, see, if the woman, usually the woman will present with pelvic pain, pressure, discomfort relating to bladder, and there will be pain relief after voiding along with one or the other urinary symptoms, and there will be absence of any other identifiable cause, like the already urine dipstick would have been done, and there will be no UTI. Okay, so pain or pressure with relating to bladder, relief with voiding, with one urinary symptom and no identifiable cause for at least 6 weeks to 6 months. Then the diagnosis will be bladder pain syndrome. Okay, so you can directly get a question out of this definition. And interstitial cystitis is a term given for histological and cystoscopic based there are proven. Okay, then you give the term interstitial cystitis. Next, coming to investigation. So again, first option will be always, because this bladder pain syndrome is increased or triggered by a lot of dietary and fluid factors like acidic drink, coffee, chocolate, citrus fruits, all this. So first step will be to keep a bladder diary and food diary for 3 days, so that you can address and identify those trigger. Next, always do a urine dipstick to rule out UTI, and the other investigations are optional. Okay, so urine cytology, cystoscopy, again, it is not routinely done, only to rule out malignancy. Okay, so basically bladder pain syndrome is a diagnosis of exclusion. Okay, there is no definitive investigation to say that this is bladder pain syndrome. Okay, next, coming to the management option. So there is a chart, big chart given in the guideline. Okay, so I have just summarized that chart. So always your first step will be conservative management. Okay, like analgesia, simple analgesia for 3 to 6 months, and stress relief, fluid modification, dietary modification. All this will be a first step, first line. If that fails, then you have to refer her to the secondary care. Okay, In secondary care, you have got some medical management option, that is amitriptyline and cimetidine, but always choose amitriptyline over cimetidine. Okay, amitriptyline, second line. And if this doesn't work, then your next step will be to refer her to MDT with or without clinical psychologist. Okay. So after that, your third line management will be intravesical injection. So there is a list of intravesical injections given in your guideline. Please go through that, like hyaluronic acid, botulinum, lignocaine, DMSO, and also in the bottom, there is also mentioned what all not recommended. There are some intravesical BCG antibiotics which are not recommended. So please go through that, because there can be direct questions out of it. Okay. So the third line will be intravesical injection. Fourth line will be oral cyclosporin A and neuromodulation, that is posterior tibial nerve or sacral nerve stimulations. Okay. The fifth line or the last step will be cystoscopy and major surgeries, like cystoscopic via cystoscopy. You remove the Hunner. This is usually done if there are Hunner lesions, which are classic of interstitial cystitis, like removing those lesions with the laser, everything. So this surgery is the last resort. Okay. So just go through this chart and remember the sequence of management steps, because this sequence can be as a direct questions. Okay. So this was all about bladder pain syndrome. And also there is a chart of classification of bladder pain syndrome, wherein the Hunner's lesion is given as grade 3. Okay. So that also you have to go through. Okay. That is also one important thing. So this was all about bladder pain syndrome. So we have covered the important topics of incontinence, vault prolapse, some important things about POPQ and bladder pain syndrome. I hope it was clear. And all the best for your upcoming exam. And please don't miss out on urogynecology module, because this can be one of the simplest and scoring module. Thank you and all the best.